in abortion care, which I did at St Mary's Hospital in London. So one of my main interests is in abortion care. So it's just to run you through abortion care in summary. It's a bit of a long presentation. I'll try and summarize it as much as I can. If you've got any questions, then please just ask. Okay, but we'll get started, and sorry for the delay. So next slide. Okay, so these are the old curriculum competencies which I had to work towards when I was a ST1 and 2, and obviously you guys, your curriculum's all changed now, and it's all gone onto the new portfolio, which I know has been a bit stressful. So I've updated my slide, and on the next slide there's how these competencies tie into your new SIPs. So I guess you can categorize abortion care as it does cover quite a few of your new SIPs. So managing sexual well-being, the acute gynae workload, you will come across these patients on your acute gynae take, especially with the pandemic recently. We've had quite a few patients who've had treatment with BPAS or Mary-Stopes that have needed to come to A&E with heavy bleeding or pain. So you will see them. Managing early pregnancy complications, it comes under that. Managing bleeding, understanding ethical principles, and I'll talk you through the basic law principles of abortion care, and then facilitating women's decision making and providing treatment. So I'm more than happy at the end of the presentation, if you want to send me across some links to the SIPs, I'm happy to fill those in for you, because I know that you don't get very much coverage of abortion care in the rest of your training. It's a little bit it's not really covered, unfortunately, so hopefully I cover it all today for you. Next slide. So introduction. There's about 25 million unsafe abortions take place worldwide. So we are trying to get that number down. And the problem is in countries where abortion is not legal, the problem is women still seek an abortion and they have them done unsafely by people who aren't trained to perform them safely. So this is where this statistic comes from. So we believe that safe abortion should be available and accessible to all women. And that's what the RCOG really highlighted a couple of years ago on International Women's Day. That should be performed in line with best practice. There is a best practice abortion care paper, which you can find on the Royal College website. And we do know that if it's performed safely, that it is actually, the complication rate is lower than childbirth. And by the age of 45, 1 in 3 women will have had an abortion. So it is really common. Next slide. So the service provision, things are a little bit different in Thames Valley to what. So I started my training in Newcastle, and our abortion care services there was all done in just within the NHS hospital. So our abortion care services were provided by the gynecology ward, an early pregnancy clinic. So it was all in one. So when I moved down here and finished my training down here, it was a little bit of a surprise to find out that the abortion care services was very different and was provided very much by independent sector companies like BPAS, who are the British Pregnancy Advisory Service. Still NHS funded, but it's very much taken away abortion care from NHS hospitals. So the training isn't quite there for the trainees anymore because we just don't get the patients. We're not providing that service. So what we used to do in Newcastle and what we did at St Mary's as part of my ATSM was providing a full package of care, including contraception, sexual health, referral to a SARC centre, which is for any patient who's been assaulted, counselling and support, and then an initial assessment. That's usually done within 5 days of the GP making the referral. Next slide. Next slide, if that's okay. Is it frozen? Can you guys still hear me?
Yes, we can. We can
Yeah,
hear you.
okay. Baljinder, is it okay to go to the next slide, please? Thank you. Great, thank you. Sorry. So out of all the ATSMs, there's 20 available to do. I know that abortion care has recently changed to an advanced specialty module. It's not an ATSM anymore. But it's just to give you a bit of a background. So since 2007, only 33 trainees have completed the ATSM, and there's only 13 that are currently registered, me being one of them. So it's a bit neglected, unfortunately, and we're trying to get a little bit more interest in the area, and it has been made into an ASM, so it's more accessible for GP trainees, for instance, to do, and also it's becoming part of the early pregnancy and acute gynae ATSM, so there'll be a optional part to do some abortion care training as part of that ATSM as well, just to get a bit more interest in it, because our surgeons who are trained in doing second trimester later surgical TOPs are really few and far between in the UK, and the college is quite worried that by the time these people retire, there's not going to be anyone that's going to be able to provide the more complex surgical cases workload.
Ms. Granger, can I interrupt and ask a question?
Yeah.
So I don't really know, what is the difference between an ATSM and an ASM?
So good question. There's not that much difference, to be honest. The only thing so the ASM is available to Royal College trainees, but they've made it a little bit broader so that GP trainees and the Faculty of Sexual and Reproductive Health, the community doctors can access it as well. So it's basically so that more people can do the training in abortion care.
Perfect, thank you.
Okay. So where did we get up to? Yeah, so there's only one person that's completed the late surgical module up to 2016. I don't have the stats for the last 4 years, but there is just, because of this, there's just a lack of opportunity and a lack of exposure to the area. So, there's a lot more of us around being Royal College trainees as opposed to the community sexual and reproductive health doctors. So we do have a bit of a responsibility to be training in this area, and it is very much part of O&G. So there's big discrepancies across the UK in abortion care. And as I was saying before, most of the training is provided by NHS hospitals, but we're not getting the cases there because we don't have the service there. So it is a bit of a problem, which slowly is hopefully going to get better with a bit more awareness of the problem. Next slide. It keeps getting stuck, doesn't it? There we go. So that's quite a famous photograph of our lovely Donald Trump. So I found that photograph quite powerful because that's lots of men in a room wearing suit and tie and looking very smart and making a huge signing a document which says that women in America can't access abortion care, and technically making it illegal in some states, and there's not a single woman in that room. So it's quite a powerful photograph, and I just thought it was worth putting on there. So underneath, just some stats again. So 1 in 3 women will choose to have an abortion at some point in their reproductive lives. And it's just to show you that with the other things like miscarriage or fetal anomaly, ectopic and molar pregnancy, actually abortion care is much more common. So maybe we should be directing a bit more of our resources and training towards this area and making it part of early pregnancy care as well, because it is stressful for the patients to go through. Sorry, this is basically what I'll do is I'll send you all the presentation at the end, but this is just a really good link to the International Women's Day from 2017, which really focused on abortion care being the RCOG's responsibility. So there's just some links there for you that I thought you could have a look at in your own time. Next slide. So some of the legal stuff. So we know that the Abortion Act was passed in 1967, which said that a person shall not be guilty of an offence when a pregnancy is terminated by a registered medical practitioner if two registered practitioners are of the opinion formed in good faith. So the person who actually performs the abortion must be a doctor. Two doctors usually have to sign the HSA1 form unless there's a dire emergency. So usually we get the two signatures. So the first signature is usually by the patient's general practitioner before they refer the patient on, and then the second signature is usually by the doctor who performs the TOP. There's 5 grounds for the abortion on the form. I've got a copy of the form in one of the next slides, and they're labelled A to E. The most commonly used ones are C and D, which are terminating the pregnancy under 24 weeks because of socioeconomic reasons. So the woman feels she can't cope, for instance, or for mental health reasons. The emergency grounds, as I said, do not require a second signature. So that's if you're concerned about the life of the patient. So the HFEA did say that only grounds C and D should have the gestational limit of 24 weeks. There's no limit for grounds A, B, or E. The Abortion Act has really radically changed abortion from being an unsafe procedure in quite a clandestine setting to safe procedure in a medical setting. If you guys want to watch quite a good film which portrays abortion only about 50 years ago, actually, not that long ago, it's a film called Vera Drake, and it's about a regular housewife in the 1950s who basically used to support the women in the community and provide them with abortions. She wasn't medically trained, but then she ended up unfortunately getting arrested and going to prison. But it's a really interesting film. I quite enjoyed it. Next slide. Thank you. Okay, there's a picture of the film on the left. So I don't know, in your own time, if you get a chance to watch it, it's quite interesting. And this is just a copy of the HSA1 form. And as I said before, it's about 98% of TOPs that we do are due to the most common reasons being socioeconomic grounds, according to the government statistics in 2017. Next slide. So characteristics just to be aware of. So medical, obviously, says on the tin it avoids surgery, mimics the treatment that we give for instance, a miscarriage and mimics a miscarriage. It's controlled by the woman and it can take place at home under 10 weeks of gestation. You need to let them know that it does take a bit of time to complete. It's not, 15 to 20 minutes like having a surgical procedure. Timing sometimes can't be predictable and it can go on for a few hours or so, if not a couple of days. They need to be expecting to have bleeding and cramp. That's a given. So they need to be really well counselled and to make sure that they're sensible and can cope at home with these side effects. They may require more clinic visits or follow-up, for instance, if they have further bleeding or if they've still got a positive pregnancy test and you're thinking that they've got RPOC. As well, medical might be necessary for patients who aren't really suitable for a surgical, such as if they've got a really high BMI, or if they've got some uterine malformations or fibroids, which would make actually getting into the cavity of the uterus really quite difficult. And some patients we find they don't want an anaesthetic, they don't want a surgical procedure. Next slide. Surgical is a little bit quicker, as we know. A complete abortion is, I guess, more easily verified because we can evaluate, does the uterus feel empty, and we can also look at the aspirated products of conception. Surgicals or manual vacuum aspiration I quite find helpful because we can actually place a coil afterwards for contraception, and we tend to do that at the same time if the patient wishes. But it does require instrumentation of the uterus, and there's a small risk, obviously, of uterine or cervical injury, which you need to counsel the patient about. Next slide. So in the consultation, sorry, I'm not trying to teach you all how to suck eggs. So obviously just making sure that we give them information in a supportive way, saying that abortion, it is a safe procedure for which major complications are very rare. The earlier the gestation when the TOP is undertaken, the safer it's more likely to be. The risk of failure is about 1 or 2 per 100 patients. And we need to be counselling them that there might be a small risk of further intervention to complete the procedure if they have medical complications such as severe bleeding requiring a transfusion. It is really low, less than 1 in 1,000. Gets higher beyond, with the higher gestation pregnancies beyond 20 weeks. Uterine rupture with medical TOPs in the second trimester is again low at less than 1 in 1,000. And with regards to surgical cervical trauma, about 1 in 100. But it's much less likely if we give them some cervical preparation beforehand. So usually do give them misoprostol. I quite like it to be given a good 2 to 3 hours before them having the procedure, just so it really does soften down the cervix and makes dilating the cervix up easier. Uterine perforations in the remit of about 1 to 4 out of 100 cases. Next slide. So we just need to reassure women as well, there's no proven associations between abortion and subsequent ectopic pregnancy, placenta previa, infertility, or breast cancer. It is best practice that we discuss contraception with them, and ideally if we provide that at the same time that the abortion is undertaken, they're much more likely to adhere to a good long-acting reversible contraceptive if we give it there and then. They're much less likely to come back for a follow-up consultation to have some contraception sorted out then. So I always try and send everyone home with something. Confirming the pregnancy and gestation. So I quite like to do this. I do scan patients in the clinic and confirm what gestation they are. It's not on the NICE guidance. So the NICE guidance actually says for abortion care, they don't have to have a scan beforehand. But you should be scanning them, obviously, if they have any risk factors for ectopic, or if they're giving any unusual history or symptoms where you think we should rule out an ectopic in this situation. So I guess you have to take that with a pinch of salt and just be sensible that you're triaging the patients properly. We need to assess that the patient fulfills the terms of the Abortion Act. STI screening is really important as well. We offer that at the same time. And then prevention of any infective complications. So we give prophylaxis with azithromycin and metronidazole or doxy before the procedure. It just depends. And then we do have to fill in the respectful disposal of pregnancy tissue form as well if they're having a surgical. Next slide. So medical TOP. So we use MIFI in combination with misoprostol. That's been shown to just shorten the induction abortion interval and reduce the side effects. So up to 9 weeks of gestation, we give them a 200 milligram dose of mifepristone, and we usually give it there and then in the clinic if they're very set on having medical once they've signed the consent form. So we give them the Miffy that day, and then we give them the tablets of misoprostol to take home with them, and ask them to get some simple analgesics for home as well, like ibuprofen and paracetamol, and then advise them to take the misoprostol 48 hours later. If they're not bleeding, it's best to take the misoprostol vaginally, because this has a better side effect profile than taking them into the mouth, so buccal or sublingual. You need to let them know as well that the success of the misoprostol is more with the vaginal uptake. Taking it orally gives them more side effects, so it can give them quite a jippy tummy, make them feel sick, etc. After this gestation, so 9 weeks plus, they're really not that suitable for home medical management, and it would need to be more an inpatient thing, just because the products are bigger, they're going to have more cramping and more pain. So from 64 days gestation, they have essentially the same mifepristone orally, but then they'd have the Miso 800, but they have the Miso again at 400 micrograms every 3 hours from there. So it's very similar to how you would deal with a medical management, for instance, that's coming to labour ward with a fetal abnormality. Side effects with Miso: crampy pain, bleeding, nausea, vomiting, diarrhea, flushing. And as I said, those are it's better tolerated if they take the Miso vaginally. Next slide. So early medical abortion. This is really what, during the COVID pandemic, this is what BPAS and Mary Stopes have really been doing for the last 9 months, so that they can still provide women with an effective abortion care service. So in August of 2018, the second part of the medical abortion law was passed, and saying that the second part of the treatment can be taken at home. So that was a huge change in the way that abortion care services were being delivered. You know what the medications do, as I said. So this oral sublingual route, it's less effective. So we always tell women to try and take the misoprostol vaginally. They can take the Miso at the same time or under 24 hours after taking the mifepristone, but they need to be aware that there's a higher risk of failure in this situation. So we always tell them to please wait 48 hours really before taking the Miso. You can consider an additional dose of misoprostol if they haven't passed products within 4 hours of having the initial 800 of Miso. So some clinics do actually give an additional dose for the women to take home, and tell them to put that in as well after 4 hours if they haven't started bleeding. Risk of incomplete abortion is in the remit of 5%. Risk of ongoing pregnancy is low at 1%. We tell them that the median duration of their bleeding is around about 12 days or so if they're about 8 weeks pregnant. And the median blood loss is actually, it's only just under 100 mils really, so not too bad. So when I tell patients that, they know a bit more what to expect and what they're looking out for. Routine ultrasound scanning is not required, but we mentioned before, careful triaging is really, really important. And if you're not sure, my best advice is to scan them. For home medical management, you need to select the patients quite carefully. Just make sure that they're sensible and that they know what's going on and they understand all of the instructions, because you're giving them medication to take at home. They need to understand what's going to happen and what's going to what to expect. We don't need to give them anti-D. if they're under 10 weeks. Pain, they need to know that they are going to be in pain. We work up the analgesia ladder, so I always tell them to have ibuprofen and paracetamol at home. You can prescribe them with a weak opiate as well to take at home, or something like cocodamol even, and just hot water bottle and being in the home environment can help. Next slide. These are some quite good little cue cards that the Royal College have published on. There's an abortion care e-learning module that you can do, and this is on the early medical abortion e-learning module. So I actually use these to give to patients. It's just so they've got a few cues as to when they need to seek help. Next slide. And that's another one as well, just a bit of a checklist. Sorry, it's really poor quality. And the contraindications, they're the contraindications for medical. And in those situations, you'd be really thinking this patient's much more suitable to have a surgical TOP, which we'll move on to now. So next slide. Just a little bit of background about how the abortion care services have been working during the pandemic. Recently, just in September, we had International Safe Abortion Day. There's a really good webinar. I think you can still watch it actually on the Royal College website. And they talked about a really good cohort study of the 3 big TOP providers in the UK and how the service has been running during the pandemic. And actually, things have been going quite well considering. They've managed to maintain a service. It's been one of the quickest transformations in clinical care in history, delivering, a telemedicine service. The women have actually reported better privacy and safeguarding. They feel like the care has been more women-centered, and the huge change has been that the waiting times have been massively reduced. So because the women are being triaged by phone, they're selecting what treatment option they want. They're not having to wait a long time to go onto a surgical list. They're not having to wait a long time for a face-to-face appointment. So we're actually catching them at a lower gestation. So most of the women are much more suitable to have the home medical management. So that's really good news. So in summary, it's been a high volume service and it's been successfully set up. And I think a lot of people have been quite nervous about, oh gosh, BPAS are sending tablets in the post and that's really dangerous. But actually, things have been okay. Women have been, in general, well cared for. Ectopics haven't been problematic and they have been appropriately triaged. So if they feel there's a concern in the history or anything, they've been brought in for a face-to-face appointment and they have been scanned. Next slide. So surgical TOP, I was saying before, so we should be considering giving some cervical priming for all patients, whether they're going to have a surgical evacuation in theatre or whether they're going to have a manual vacuum aspiration. I think it's really good practice to give them cervical prep. It just makes your procedure more straightforward and it's reducing your risk of perforating or causing any injury to the cervix. It's much more easily accessible. I'm going to talk to you a little bit about MVA versus electric vacuum aspiration. I've just done a couple of manual vacuum aspirations this morning. We do them at Wexham. We do them under local anaesthetic, and we do them up to 10 weeks gestation, but it's purely at the moment just for early pregnancy services, so the miscarriage patients, and we don't have a TOP service at Wexham. But the MVAs do translate quite nicely into early pregnancy care as well. The higher gestations, so over 14 weeks, we tend to use either vacuum aspiration using a larger cannula or we do a procedure called dilatation and evacuation, which I'll go through in a little bit. Next slide. So with regards to a surgical, it's generally done under an anaesthetic or conscious sedation. So at Mary's, we used to just use conscious sedation. So it's really quite a fleeting anaesthetic. The patient wasn't tubed or anything, so they just have some conscious sedation, be a little bit drowsy, and then we do the stop. So we perform a bimanual, pop the Valstellum on, and then we dilate the cervix up as needed. We dilate higher if it's a higher gestation. All of the TOPs that we did at Mary's, we do them under ultrasound guidance. So we watch as we're dilating. We've got a really good view, and we can make sure that we're not going in the wrong direction and that we're going into the uterus. And then we use a suction curette equating to the gestation of the pregnancy and introduce that into the cavity. As I said, in patients who've got a scarred uterus, so previous sections, ultrasound guidance is really, really helpful because these are at a higher risk of perforation. So the main ways that we minimize complications is by using ultrasound guidance, good cervical priming, and just good operator technique, basically. And then afterwards, once we've removed the pregnancy, it's really straightforward to pop a coil in straight away, and the patient's got the contraception sorted then. We don't routinely do histopathology of the products of conception, not unless we're querying a molar pregnancy. With regards to dilatation and evacuation, so we do that technique for pregnancies that are further along, so 14 weeks up to 23 plus 6. We always use ultrasound guidance for these, just so that we can see what we're removing, what's left over. We usually dilate up to about a size 11 or 12 with the Hagar, and then we use sponge holding forceps or grasping forceps to remove the fetal tissue. Sometimes what I tend to do as well is just rupture the membranes with the suction curette first, and then go in with the grasping forceps. You need a bit of a strong stomach, unfortunately, and these women need to be aware that if, for instance, if they're having a TOP for a fetal abnormality, they need to be aware that in higher gestations that the fetus is removed, unfortunately, in piecemeal, unfortunately. So you need to factor that in, because if they want to see the baby afterwards, or if they want any post-mortem, for instance, that's going to be more technically challenging. That is, yep, I've mentioned everything on this. We can go to the next slide. So analgesia. So the aim is to reduce pain and distress for the patient. So mainly what we're trying to do is limit their awareness of the procedure. So usually conscious sedation is enough. The NICE guidance does recommend considering local anaesthetic alone, conscious sedation, or general anaesthetic. So it's really about considering the wishes of the patient, the gestation of the pregnancy. Has she got any other comorbidities? Do you think she's going to bleed? All of those factors, and then just making an individualized plan for the patient. So for a routine stop under 14 weeks, local anaesthetic and conscious sedation may just be sufficient, and they don't need a full general anaesthetic. What we're trying to do, especially with COVID at the moment, is to try and reduce the number of women who are going for a surgical management of miscarriage at Wexham. So we're trying to really promote our MVA service, because we know that use of local anaesthetic alone means there's no need for the patient being nil by mouth beforehand. They're in hospital for less time. They don't need an escort home. They don't have the horrible side effects when they wake up of having the general. They don't feel sick. The recovery is much quicker. So manual vacuum aspiration is really a good option to have. If we do use conscious sedation, we usually use propofol and a short-acting opioid such as fentanyl. So that's for general anesthetics required, and they're pretty short-acting. You need to be aware with these patients that are having a general, they can make the uterus relax more and cause more bleeding. So just to bear that in mind. With conscious sedation, we usually use midazolam. Next slide. So priming, sorry, this is a bit of a wordy slide. So up to 14 weeks gestation, we don't always need priming, but my best advice is to always give priming, because it just makes your procedure more straightforward and helps getting into the uterus. So generally we use misoprostol. You can use mifepristone, or you can use a mixture of mifi and miso. There's a little device as well that St. Mary's used. It's called Dilapan. I don't know if you've heard of that. It's basically an osmotic dilator. It's made of seaweed, and they're like matchstick-sized rods that you just put into the cervix 24 hours before them coming back for the evacuation, and they swell up and open the cervix manually. So it's almost like having an induction balloon in, essentially. We usually put about 3 or 4 in, and it can dilate the cervix up to a good few centimeters open, enough to get the sponge holding forceps in to do the procedure. We always use osmotic dilators like Dilapan if they're higher gestations, so after 19 weeks gestation. So it just depends what's on the formulary in your hospital. Next slide. Complications. So we've already gone through this, actually. I've already mentioned this, so we will bypass this. That's fine. I've already gone through that. So next one. Complex care. So, sorry, just back one. There we go. So women with comorbidities, so things like epilepsy, diabetes, anything with the heart. These patients, if they're quite complicated, the independent sector unfortunately can't manage them in a community setting. So they're usually referred to an NHS unit offering specialist abortion care. Now, these units are few and far between. There's not very many of them. So you do end up in a situation where if a patient, say, is from the Northwest and has seen BPAS and is in the first trimester but has underlying, I don't know, poorly controlled diabetes and is really quite anemic and has a fibroid uterus and a high BMI, BPAS can't do a surgical for her because they're a community clinic setting. And these patients are quite high risk anesthetically, so they have to come to a tertiary centre. They usually get referred quite a long way. So the specialist abortion care centres are, off the top of my head, there's one in Newcastle, there's 3 in London, so Mary's, King's, and I can't remember the other one. There's not many of them, so they have to travel quite long distances, and then unfortunately they end up having to wait a little bit of time, and then they go from first trimester to second trimester, and it's quite stressful for the patient because they get further along in their pregnancy and end up needing a dilatation and an evacuation because the referral process and you know, the distance they're traveling just takes a lot of time to organize, because they have to find someone that's appropriately trained to do their abortion for them. So there's a big disparity in the proportion of abortions that are done surgically at higher gestations. And that's the problem we've got with the current abortion care services. So BPAS are doing, you know, the best that they can in quite difficult circumstances. At St. Mary's, we used to get quite a lot of ladies over from Northern Ireland as well. So they would get a flight over and then come for their face-to-face consultation, and then they'd have to book a hotel for 5 days to a week or so until they could be squeezed in for their surgical. So it's really horrible experience for them. Next slide. So manual vacuum aspiration. So this is what we're trying to work towards, offering more women this procedure, especially with early pregnancy care as well. These are really useful for the missed miscarriage patients or any patients with retained products of conception, and any TOP up to, we go up to 10 weeks gestation at Wexham. So it's quite low cost and low technology. It's a really simple bit of kit, but it works really, really well. And it's just as effective as the patient going for a surgical. So the two I did this morning, we did it in an outpatient clinic setting. So like a hysteroscopy suite with a chair that goes back, good lighting, good equipment. We did it under ultrasound guidance. The patient had misoprostol beforehand and then put a diclofenac suppository in 3 hours before as well, so just so she was more comfortable. We do a block in the cervix just for more analgesia, and then do the actual MVA procedure. And then afterwards, I did a quick transvaginal scan as well, just to make sure that the uterus was empty. So it seems to be going well. It seems to be well tolerated, as long as the patients are appropriately counselled beforehand. And that's what we're working on. Next slide. Oh, this is a really old poster that I did for the Congress in, oh gosh, when was it? I think it was 2015. So we set up the manual vacuum aspiration service in Sunderland Royal. So I originally did my training in Newcastle, and that was my poster. So we can move on to the next slide. So my ATSM, so I did it with Miss Nair in St Mary's, wonderful supervisor, really keen to teach. She is looking for anyone else that is wanting to do the training. And St Mary's offers early medical TOP care, late medical and surgical TOPs up to 18 weeks. It is in the process of going up to higher gestations, but currently they do go to King's College. And we've talked about, the huge distances that our patients travel to come to the clinic at Mary's. Next slide. Useful reading. So there's quite a bit on the RCOG website. There's a good evidence-based guideline. There's a new guideline come out, which is in line with the pandemic with abortion care. So have a little look. There's the nice guidance as well that came in a couple of years ago as well. Next slide. Oh, that's just a nice photo. That's the summit at Kilimanjaro. Beautiful sunrise. And then that's my email addresses there, just to send me some tickets. So the top one, it hasn't come through very well. So it's rose_barrow at live.co.uk. And then all my NHS ones fine. But I've got two names, sorry. Barrow's my maiden name and Granger's my married name. So I have two names. That's everything. I hope, sorry, that's a bit of a whistle-stop tour of abortion care. Does anyone have any questions? Or am I safe to run back to labour ward?
That was really helpful. And yes, a lot to take in. And you're right, we don't get enough training, do we?
No.
And I wonder, as ST1s and 2s, maybe that you guys haven't had much exposure to women who possibly have had complications or wanting terminations at later gestations, but it will definitely be a theme for you guys at some point. Does anybody have anything they want to ask Rosie or make any comments? I've got a couple of things, but I can hold back for the moment.
Do I show conversation?
Oh, Putri?
Hi, Petrie.
Hi, Rosie.
Hi.
Can I just ask a question?
Yeah.
Recently, thank you. Recently, we had a lady who had RPOC after a MTOP from BPAS, and I think she was around 12 weeks or 13 weeks, and
Okay.
she didn't have anti-D after the MTOP.
Right.
And then she came to us with written product
Oh,
like
dear.
about 5 days after the MTOP.
Okay.
So do we still give the anti-D like within 10 days period, or how do we deal with this?
So how long since the MTOP was it?
5 days.
5 days. So I would have still given it to her, yes, especially if she had retained products. So did she end up going for a surgical, or did she have an MVA?
She had SMM.
Okay. So I would have still given it to her. Yes, despite it being 5 days later.
Is there a set time frame, Rosie, like such as 72 hours with someone that's pregnant and has bleeding? Is there anything like that?
So the NICE guidance, it's a little bit thready, the guidance, and for medicals under 12 weeks, it says that we don't have to be giving anti-D. So it's a tricky one. It comes up quite a lot, but my general rule of thumb is anyone that's over that gestation, or 10 weeks, not 12, 10 weeks, anyone that's over that gestation, or anyone that's having instrumentation of the uterus, so an MVA or an SMM or ERPC, should be having anti-D.
I guess there's no harm.
There's no harm, no, exactly.
Vinod?
Hi, Rosie.
Hi.
I've read a lot of things around this, even prior to COVID and after COVID. It makes even more sense because the partners in these cases weren't allowed to attend in hospital to support their female partners who are undergoing the procedures. So would you like to comment on anything? Because men often feel that they're left out. Obviously, they don't have any right in the decision-making process because this is still part of the woman's body. Can you comment on that, and especially in the post-COVID scenario?
Oh, that's a good question. So generally, from my experience, the patients that I've seen in the abortion clinic, we're very happy for the woman to come on her own. We're very happy for the woman to bring her partner. So we do try and make them both, you know, if the partner wants to come, we always try and make him take part in the decision-making process with the patient. But we do have patients where the partner's not aware of what's going on as well, and it can be very sensitive. As I said before, we do have patients who have been sexually assaulted or domestic violence cases. So it's really, really sensitive thing. So we only tend to bring the patient's partner in if she is, 100% comfortable with that, because ultimately she's the patient, and it's her body, it's her decision, and that's what we do. Yeah.
Thank you. Rosie, can I just ask, so I have to say, we were all horrified when we heard that BPAS and Mary Stopes are sending out these
I know.
You know, we've been doing datexes because we had some
I know
as a possible ectopic. So one, it probably wasn't advertised very well. What I'd like to know is actually, was there any downside to it? Have there been ectopics that have been missed? I mean, is the information, has it been collected yet? Where
the
would
information?
It be?
So the information is being collected. So, in September, it was International Safe Abortion Day. They did a really good webinar about the abortion services during the pandemic. And they've done a cohort study, which is still ongoing. So they've got some of the stats back. But that study actually showed that they haven't, the rate of missed ectopics hasn't gone up. So far. It hasn't increased. Because they are triaging patients appropriately. So no, I was the same. I was horrified as well when I heard about misoprostol by post, but actually, when I listened to the webinar, I did change my opinion, because the stats that they've published are really, really encouraging. So
I'll definitely watch that webinar.
It's on the RCOG website. It's still there. If you put in Google International Safe Abortion Day, it'll come up. And
very lastly, can I just share probably one of the most remarkable cases of my career so far? Obviously, it doesn't take much to get me excited. We've had a patient recently who had a termination at BPAS. Oh no, she went for a termination, surgical termination, and she sustained a uterine perforation. So that's the first thing. I haven't crossed that yet. Obviously, since however many will happen. And she came in, so obviously we had to take her to theatre, had a delayed laparoscopy, theatre was busy and things. Anyway, one of my colleagues did had a look, she had a bit of bleeding, dealt with the perforation, and then obviously she had to do the termination. This patient was 12 weeks and 3 days. So she did the termination, but she didn't get much tissue, and unfortunately she scanned the patient afterwards and she was still pregnant. So I don't know if you've ever come across this, but this patient had a non-communicating uterine horn, and that's where the pregnancy was. It's just, I think it's remarkable. But anyway, short of it, just because I know everyone's probably wanting to get some tea and coffee, she went to King's and they confirmed that this was the case, what we had suspected, and they've surgically managed the pregnancy. They've removed the horn. What I haven't been able to establish, and I need to follow this up, would they have performed? Would they have given anything for the termination, or do you think they would have just removed the horn surgically and just dealt with it like that?
I think they'll have almost dealt with it as if it was an ectopic, I guess, and just removed the horn surgically.
Yeah.
And then maybe followed up with HCGs.
Yeah, no, that's what I was thinking. As I say, I need to find out, but I've just, I thought it was
really interesting case.
Really interesting.
Because we had I don't know if you remember at Reading, there was a patient, a couple, it was before I left, it's probably a few months ago now, that you know, when we get these cases where it's a second trimester miscarriage, so a late miscarriage,
and
that they only have the option of going for a medical on delivery suite usually, and this poor patient had I don't know how many rounds of miso, and then had oxytocin, and she just didn't labor, and she had lots of bleeding as well, lots of APH, and I think she got up to about 1 litre. And she'd had 2 previous sections, if I remember, and it was really tricky because everyone's so anxious about doing sort of higher gestation evacuations, and I think that the safest plan for her in the end, and it's what we did in the end, thank goodness, and she went to theatre and had a dilatation and evacuation and ultrasound guidance. But that's it
does get very tricky, you're right, and it's a shame that there aren't quite the specialist services
for them.
And last couple of things then, is it right that any perforation needs to be reported to the CQC? This is what the doctor from BPAS mentioned, and I said, oh, okay. But I thought, it's a perforation, it's an expected complication.
I wasn't of the understanding it had to be. I can check with Vanita Nair's, like the oracle of all knowledge. I'll ask her. Okay.
All right.
That's not something I was aware of. No.
Okay. All right. Great. Well, thank you. I will.